Hello and welcome to Health Matters on Channels Television. Thanks for joining us. I am Mary Alale Yusuf. There's an outbreak of diphtheria in Nigeria. Already, 25 people, mostly children, have died from the infection in Kano. There are also confirmed cases in Lagos, Osun, and Yobe states. Diphtheria is not a new disease. It is one of the killer diseases children get immunized against under the Expanded Immunization Program, EPI, since its inception in 1974. According to the World Health Organization, vaccination against diphtheria has reduced the mortality and morbidity of the disease dramatically. However, it is still a significant child health problem in countries with poor routine childhood immunization coverage. In countries endemic for diphtheria, the disease occurs mostly as sporadic cases or in small outbreaks. Diphtheria is fatal in 5 to 10% of cases, with a higher mortality rate in young children. My guest is a consultant public health physician, Dr. Akiala Ishaku. He joins us at our Abuja studio. You're welcome to the show, sir.
Thank you, Mary, for having me, and Happy New Year, viewers.
We wish you the same. Now, I found myself in shock that we had cases of diphtheria killing people in Nigeria. I mean, we've been taking this vaccine for ages now. Has this happened since we started the EPI? Has it happened in Nigeria before on this scale?
No, I think this is the first time it is happening in this scale. And I want to thank you for establishing a very robust background on looking at the epidemiology, the world landscape, and you also had a funnel approach to the disease indices within developing countries or nations. Since the expanded immunization program, we never had such kind of sporadic cases of diphtheria with also high fatality, case fatality rate the way we are having. Just like you established from the beginning, it was initially confirmed to be 18 cases of death, and now we have over 25 people who are dead, mostly are children. This brings to bear the national question about our national immunization program. So this connotes or this depicts two things. One is either that our surveillance is not active enough to begin to pick suspected or probable cases. Two, it is also possible that the immunization coverage is not well, we never had a very robust immunization coverage. And this also agrees with the fact that if you look at our national immunization survey that we did in 2017-2018, we had a 33% coverage in terms of the pentavalent vaccine against the world benchmark of about 90%. So it shows that, yes, we have improvement, but the improvement is not well enough. We are supposed to cover 90%, but now we are having 33% coverage. Now, so this brings to the national questions. What happens to our immunization program? The routine and supplementary immunization program. Even we had other integrated vaccines that are being incorporated within the child preventable hood vaccine routine immunization. So what happens? That brings to bear that we need to do a lot of things. One, we need to rejig our campaign strategy or vaccination strategy and actually look at where we missed it. Now, we also need to go into in-depth research to look at these cases of diphtheria, what happens to them? We need to go into the aspect of genomic epidemiology to look at, is it the same strain with the one that we routinely have? Or maybe a lot of mutations have taken place. And then we need to also see to have, we can actually make a point in terms of vaccine development, because if you go to genetic epidemiology and begin to come up with new findings that has to be associated with the etiological agent, it shows that vaccine manufacturers can also have a clue.
Can I cut you in there? Can I quickly come in there? Because what you're saying is raising so many questions in my mind. First of all, if we are having mutations, let's assume we're having mutations, it simply means that our coverage has not been good at all. That means there's been time for the bacterium to change over time. Then again, diphtheria vaccination is free, so what's the problem? It's not like they pay for it, and they give it in the child's infancy when he's still with the mom, you know, still with carers. So there's no such thing as, oh, he's in school, I couldn't get him down, or you know, something like that. What really is the issue here?
The issue is clear. I think with this outbreak of diphtheria, it shows that a lot of people have missed their routine vaccination timeline. You know that diphtheria vaccine is given at the 6th, 10th, and 14th weeks of childbirth, you know, when just like the way you say that when the baby is with the child, with the mother or with the caregiver. So it shows that a lot of people miss the vaccine. And you know that these vaccines are kept in health centers. And I think the time has come for us to reject that strategy, to look at what is the missing threshold of children that needed to be immunized for diphtheria. How many of them we missed them? So can we look at the missing threshold and begin to develop strategy on how to reach out to those kind of people? Are these strains imported strains? Mary, you know that we have very porous borders. So we need to also do a lot of epidemiological studies to establish whether these are imported cases of strains of diphtheria that are most likely to be seen in other neighboring countries that borders Nigeria. So we need to look at that. But I think we need to establish why are people missing these routine immunization or vaccines. We can see to how we can strategically target this missing threshold. Now, in the ideal, you are supposed to come to a health center for you to be vaccinated. Maybe perhaps on other routine immunization for specialized vaccines that are being taken, like the HPV vaccines that, you know, they are injectable vaccines. Is it possible for us to reach out to communities with these vaccines in terms of vaccination? So if they do not come, they say if Ali did not go to the mountain goes to, you know, there is this adage that is very common, a pidgin adage that is very, very common. So is it possible for us to reach to people at their homes and begin to see how we can be able to take vaccination down to households? Secondly, can we also come up with a national policy? Mary, why is it that we give measles vaccines and people still come down with measles? It's still the same questions that a lot of people have missed out in the measles vaccination, routine vaccine. So there are a lot of things that we need. So can we come up with a national policy to target the same age group that needed to take these vaccines? For example, is it possible for us to say that within the same threshold of school reopening, within certain classes that we know that children under 5 do attend, is it possible for parents to submit their vaccination certificates to head of schools to authenticate? By so doing, we should be able to capture people that miss vaccines, children that missed vaccines, and they are attending schools. Secondly, can we also begin to look at out-of-school children? How do we intend to target them? How do we intend to reach out to them? Like the Almajiris, like the people that hawk on the street that are less than even 5 years, or within the vaccine preventable age that they needed to take these vaccines. How do we intend to engage in kind of a social mobilization to reach out to them with a robust stakeholders engagement? And I think that once we do that, we should be able to nip this on the bud. And this is a strategy that India adopted. Instead of coming to health centers to take vaccines, India now devised a means to, you know, reach out to people in their homes, reach out to even how to reach areas. We can also look at the hotspots, to look at the IDP camps, and also look at the porous borders that we have. In time past, is it possible for us to enable immigration, enable customs at the point of entry, for us to review people vaccination status? I'm talking of land borders, not even air borders. I'm talking about land borders for us to mount and begin to enable to have a very robust immigration and custom health units that should be able to check vaccine status. Because these are
let me ask you about the vaccine very quickly. We know that there are 3 vaccines that a child takes for diphtheria in infancy. I don't know, is it now a pentavalent thing? It was DPT, you know, when my children were born. That's diphtheria, pertussis, and tetanus together. Now, they take 3 of that. Are they supposed to take more than 3? And then how immune are they once they've taken it? Is it a lifelong thing, or should there be a top-up or something?
So that brings to a very strategic, very valid questions that you have asked, whether it is a lifelong. And so it brings to bear for us to actually look at the vaccine efficacy studies. We actually need to actually do like a national survey to look at. Mary, even the COVID vaccine, we just took a jab. Nobody knew about how do our cellular immune response respond to this jab. Do we have a threshold of antibodies to these vaccines that we take? So, you know, we need a whole of, a research approach, because 21st century is a knowledge-based century that, you know, it is a knowledge-based economy. You depend solely on research that you carry out to begin to inform policy. So you ask a very valid question. In time past, we give DPT, diphtheria, pertussis, and tetanus, but now hepatitis B has been added. Even the issues of influenza B, vaccines have been added. Now we have even incorporated COVID among, the vaccine program for children. Now, it is expected that at week 6, at week 10, and at week 14, children can be able to access this vaccine. But over time, I checked some literatures. I actually did some lexicon literature search to look at studies from Nigeria. What is the threshold of, immune response to these vaccines? In fact, there are paucity of information, limited informations about that. And so these are kind of informations that improve in terms of health policy, in terms of even vaccine designs that are made mention much more earlier when it comes to issues of immunization program. So we need to have a holistic approach in terms of a whole vaccine or immunization program that we have in the country, and actually review certain strategies.
Okay, diphtheria was called a killer disease. Back when there were just 6 of them that we identified, you know, I'm sure lots of diseases have come into the killer disease list since then. Anyway, but can you tell us how dangerous is diphtheria? What are the symptoms and how does it progress?
Now, so diphtheria is actually, it can be fatal in children. It can also be fatal in immunocompromised adults, people that their immune system is being compromised, or people that have associated comorbidities. Just like the way you establish from your background, you will discover that it has about 5 to 10% case fatality rate has been established by WHO. Now, it is quite fatal, just like the way I said, in children and immunocompromised individuals. Some of the associated signs and symptoms are actually difficulty in breathing. There is what we call tonsillitis. The tonsil becomes inflamed, and the nasopharyngi becomes also inflamed. So it triggers difficulty in breathing. It comes with associated high fever. And diphtheria, the organism, the bacterium, elicits a toxin that is highly fatal, and it can also lead to a lot of neurological disorders within a short incubation period. And that's why you can see that the case fatality are very high among people that live in clusters, overcrowded areas. So you have a lot of issues associated with neurological disorders, difficulty in breathing, very, very high fever, and then there is what is called tonsillitis, the inflammation of the tonsils, and then the nasopharyngi.
Wow, that's a lot. But let's pause here. We need to go for a break. We'll go for a break now and be back shortly after. Stay with us. Welcome back. We're talking about diphtheria on Health Matters on Channels Television. The number to call is 0808-054-2233. If you want to ask a question about diphtheria, you can tweet at CTV_Mary A. They should be showing on your screen now. You can also send me email, moalale@channelstv.com. Now, let's go on with this discussion. Doctor, now, let me ask you, we know that a vaccine is supposed to prevent diphtheria, but for those who are immunocompromised, for those who haven't been vaccinated or haven't finished their vaccination, they get diphtheria, what hope that they will recover? Is there treatment?
Absolutely. There is a treatment for diphtheria if it is being identified on time. And so that is why there is need for us to see how we can improve the health-seeking behavior of Nigerians, to be able to report on time to health facilities once they have discovered some abnormal signs and symptoms. And also caregivers should be able to see how we can improve their health-seeking behavior. So there is absolutely a treatment regimen for diphtheria. In fact, in even severe cases, there are treatments. In fact, you need to isolate such kind of individuals. But you know that, Mary, diphtheria is an airborne disease. It can spread either through cough or through sneezing in an overcrowded area. So you can see that associated diseases such as meningitis, diphtheria now, and even COVID have the same mode of transmission in terms of which they are airborne or direct contact. So one of the things that we can be able to handle this is to actually engage in not engaging in overcrowded places. But yes, diphtheria, even in mild and severe cases, there is treatment for such kind of a disease condition.
I see that we shouldn't have ditched our masks so gleefully and so quick, because we could have used masks for situations like this, right? And since it's so easy to spread, and we already have 25 deaths, are we right in saying that for those 25, there are several more that haven't been discovered? How do we nip this in the bud and contain it before it becomes a dangerous thing?
So initially, I established that we need a very active surveillance system, the one that is not passive, ability to be able to do a contact tracing from cases that were being confirmed, and begin to see how health officials can be able to track those cases. We also need an emergency isolation center.
Doctor, let me pause you a bit there, just for a moment, and let's take Ada. She's on the phone. Hello, Ada.
Hello. Good morning, Mary. It's Ada calling from Jos Plateau State. Good morning, doctor. I don't know. I was really, I couldn't believe it when I heard about this diphtheria, especially yesterday, when they were showing it on television, the deaths and all that. Doctor, what my mind is telling me is that, are you sure that our primary health centers have sufficient vaccine? Because we're not usually proactive. They get close enough to the people, so whatever are so far away. And then I heard you talking about if Muhammad doesn't go to the mountain should go to Muhammad or whatever. You remember that if any health worker or caregiver wants to go to those villages, remote villages, they have to go through the traditional rulers, because we have lost some health workers before, because of illiteracy. So we have a whole lot of problem in Nigeria, but it shall be well. That's my take this morning.
Thank you so much, Ada. Dr. Shah has raised some issues. The competence of the health centers. Are we suffering a shortage? Are we hiding something? Or are we capable?
We are capable. The last time I checked the profiling of diphtheria, vaccines with the National Primary Health Care, I think that we have enough stocks of the vaccines that can be able to, service all the millions of Nigerian children and people in need of those vaccines. I want to give kudos to the National Primary Health Care for doing great jobs. Nigerians by default are people that don't even appreciate things that are free. Anytime you say that these things are free, Nigerians don't actually appreciate it. The reason why I say that Mohammed has to go to the mountain or mountain coming to the Mohammed is to devise a strategy on how to reach out to people that have missed these vaccines. And that's why I interjected by bringing that kind of analogy or a metaphoric analogy to that regards. But I agree with her that we need to upgrade and optimize certain of our primary healthcare systems. And I also agree with you, Mary, that we are so quick enough to throw away our face masks. If you check Japan, Japan has the lowest mortality rate to COVID. Because why? Over 50, 60 years ago, wearing of face masks in Japan has become a culture. And so it is a culture that has become so habitual to them that people grow up as part of a way of life to wear masks. And so when COVID came, there are a lot of things that COVID brought to us. We had a fractured healthcare system, but COVID also helped us to actually upgrade and optimize so many preventive measures that we would have sustained. Just like simple washing of hands and the face mask wearing. These are things that they are not rocket science. These are things that would have ensured that there is continuity and then it becomes habitual to these regards. But a lot of Nigerians throw it off and then we are still battling with, and I hope, Mary, you know that this is a season 2 for meningitis. So we are battling with a humid weather, and a very hardy and windy weather that most of these microorganisms, a theological agent, are suspended in the air for quite a long period of time, and they can be inhaled. So I strongly believe that we need to also devise a way. And also kudos to Channels TV for doing a lot of advocacy, just like the program you are anchoring. I think we need to do more of social mobilization in terms of health advocacy. And then with that, we should be able to pass on the message.
Thank you so much, Doctor. It's been wonderful having you. I would have liked to ask 1 or 2 more things, but we covered such a lot. Thank you so much for coming on the show.
Thank you, Mary, for having me, and have a rewarding weekend ahead.
Thank you. Thank you, Ada, for calling, and thank you, everyone else, for listening from your home, your tab, wherever you were looking at this program. Have a wonderful day, but please keep safe. Stay away from droplets. Have a lovely day. I'm Mary Alale Yusuf.